Hello? Can you guys hear me? Okay, for sure, for sure. I'm gonna give it 5 minutes before I kind of get into the meat of things, because I just want people to fill in case, they need some extra time to. But thank you for coming, guys. You know, First and foremost, like, I just want to put a disclaimer out there that, like, this term's not going to be easy for you guys, but I know you guys have come, yeah, I know you guys have come this far for a reason, and I don't doubt your capabilities and your ability to make it through this term. You just got to focus and you got to buckle down as much as you can. But I'm going to be here for you guys along the ride, and like, you guys definitely have me as a resource, and I'll put out like all my contacts, and like, you know, I'll be there. Mm. I did have Professor Sarkisian, yes, and I actually tutored this course last term. So good. Yeah, it is. But well, I'll guide everyone as much as I can. I mean, I've come across students that had I think they had Rosis as well as I forgot her name, Professor Garcia as well. So of course I haven't taken Professor Garcia or I haven't taken either Rosis or Garcia, but the things they cover in their lecture are similar to what Sarkisian teaches about. So of course, like, those that have Rosis, those that have Sarkisian, those that have Garcia, like, you're free to leave whenever you want if you feel like, you know, my tutoring isn't beneficial. Again, I'm gonna base my tutoring based on what I learned in Sarkisian, but I still think you can get value out of what I say during my session. So, feel free to stay as long as you want, but of course, like, I understand that, sometimes it's more beneficial to attend a tutoring session if that tutor has had your professor. But I'll be here, guys, and I don't know everything, so if I'm not sure about something, like, we'll look for it together. I won't just say I don't know and then just leave you guys there, but I'll try to help as much as I can.
Do you know if the other two PALS tutors, Garcia by any chance?
I'm not entirely sure, as I think the two PAL tutors, in addition to me, um, they're not in my cohort. So I haven't had much discussion with them, nor do I know what class they had the previous term, but I can ask.
Thank you.
No problem. And your emails just are, I'm sorry if I'm pronouncing your last name wrong, Bakri?
Yeah.
Okay, for sure. I'll let you know, once I contact them about it and see where, they stood last term. So,
Thanks, I appreciate it.
of course, no problem. Sorry, you guys, for those that just joined right now, I'm waiting until 1:05 because I just want as many people to fill in as possible before I start up everything. And I'll email those other two PAL tutors for you, Rajiv. See, Sorry, you guys, I'm just finishing up an email right now. Alright, you guys, hello. My name is Kyle. I'm currently in my intermediate med search term. I've been a PAL tutor for around 9 terms now. I've tutored a variety of classes such as pathophysiology, fundamentals, as well as this class. This is going to be my second term tutoring this class. And, I've had some experience, but of course, I'm still learning with every cohort I tutor. So, I just, again, for those that came in a bit late when I said this, I'm here as a resource. I want you guys to know that, I'm not only a tutor, but I consider you guys a part of my cohort as well, even though you're in a separate cohort. I think of you guys as we're just one big WCU family in some way, So if you ever have any questions about your clinicals or um, just anything with lecture, how to study for your proctored exams, I got you. Because again, even if you were on campus, you still need a village to really make it through this program. So I want to be a part of your success, and I want to contribute to it. So feel free to contact me at this email at any time if you guys have any questions, okay? Moving on. So how this is gonna go is that I plan to, provide what I think is important for you guys in terms of preparing for your quiz and kind of reviewing, again, those important points. So how I went about it last term is that I usually go through my lecture that I had taken notes on when I was in Intro to Med Surg. And I usually run through, what I feel like are the key points to prepare you guys. And I usually just ask questions throughout the tutoring session, what's your guys's level of understanding of what I think are important things. And of course, if I feel like I have to add anything extra upon that, I will. So if you guys have any questions on anything I talk about through my tutoring session, or if you want me to steer my tutoring session a certain way, feel free to just leave suggestions in the comments, or even you can turn your mic on and you can just tell me straight up, if you have any suggestions or how you want to go about things. So whatchamacallit, one last thing, I'm going to post a link into the chat box, and this link is pretty much going to have a QR code in which you scan, and when you scan that QR code, it'll pretty much take your attendance for this tutoring session. So the benefit of that is that I think your instructors can see who is attending tutoring sessions and who is not. So I think when it comes down to crunch time, when your instructors, let's say you're at a very slim point for your class and yourself, right? I think if your instructor sees that you're trying and you're doing everything you can to succeed, such as coming to the tutoring sessions, they're going to have a sense of, I wouldn't say leniency, but respect. And I think that can translate in some way to, being more helpful or providing you more resources at least to succeeding. So I'm going to post the link in right now. Just let me know if you can access it. Sorry, it might be oh, go ahead. Was someone going to say something? It might be a bit shoddy. I haven't I didn't really take the time to work out the logistics of making a link for it. But if it doesn't work, I'll just post it on the I'll just put it on the screen at the end of my tutoring session. I feel like it's not likely to work, but if anyone's able to access this link, just let me know. Okay. that was a fail, but it's okay. I'll figure it out, but I'll post this QR code at the end of my session. So okay. No problem. It's okay. All good. All right, you guys. So week 2, correct? You guys are going through diabetes? Okay, for sure, for sure.
Yeah.
So just to recap, what is the difference between diabetes and GI as well? Okay, just to recap, what is the difference between type 1 diabetes and type 2 diabetes? If anyone could point it out. Does anyone know? Insulin resistance versus absence of insulin production. Exactly. So which one is an absence of insulin production?
Can it also be because one you're born with and one you're not?
Oh yeah, exactly. And that kind of references back to the absence of insulin production. So to pretty much add on to my question, what it is type 1 diabetes. That's when your body doesn't produce any insulin. And that could be due to an autoimmune disease. There's like speculation on, what the exact cause of type 1 diabetes is. So that's why you have that lack of insulin production because your beta cells are destroyed from the jump. So if your beta cells are destroyed, which are the cells in your body that produce insulin, your body can't make insulin at all. So with type 2 diabetes, that kind of differs. And that in type 2 diabetes, your body's still making insulin. But what's happening is that your cells, they become so tired of getting that insulin, stimulation. Like they're so tired of, they're just desensitized at this point. Like imagine someone constantly tapping you with a pen on your shoulder. Over time, like it's gonna get annoying, but over time you're gonna have a sense of desensitization to it because you're being tapped so much. It's not the same as, being tapped the first time and it gets your attention. Your body, like similar to insulin, um, if you have too much insulin in your body, or if you have your body, constantly secreting insulin in order to lower your blood sugar, then eventually they're going to become resistant. Insulin resistance. So insulin resistance often occurs from cells being overworked. Exactly. It's not necessarily the cells are being overworked, but it's the cells getting desensitized to insulin because the cells are being stimulated by insulin too much. So pretty much they get over it. Like they're like, okay, like you've stimulated me too many times, so I'm not going to respond in the same adequate way. Does that make sense, you guys? Okay, for sure, for sure. Anyone, is that confusing for anybody? Any clarification there? Okay, for sure. Again, you guys just feel free to type in the chat or speak up if I say anything that's confusing, okay? So, oh shoot, whoops. So when we think about
I'm sorry. I hate to interrupt you, but
oh,
can you, I guess try to explain it to me again, because I'm understanding that you're saying the cells are constantly getting, I guess like you were saying, tapping on them, like constantly getting tapped on. So
yes,
they're starting to ignore the insulin, but how are they getting tapped? Is it by the excessive glucose? Is it just in general?
it's more the excessive insulin secretion and stimulation that's caused by the constantly high blood glucose levels. Does that make more sense?
Yes.
Okay, no problem.
Thank you.
Yeah, of course. So when we think about diabetes, you guys, what are 3 comorbidities that are associated with diabetes? So I'll give one of them. One of them is retinopathy. Okay, so nephropathy, renal failure, and we have nephropathy and we have retinopathy. What's the last pathy we have? What's the last associated comorbidity we have? You could also see cardiovascular disease as well, because I think that extra glucose damages the vascular system. But yeah, exactly.
Neuropathy?
Yeah, neuropathy, exactly. So the 3 comorbidities we're likely to see with diabetes is nephropathy, so kidney damage, retinopathy, damage to the eyes, and neuropathy, generalized nerve damage. Um, let's see what else. Okay. As I don't know who exactly mentioned this, as someone had mentioned in our tutoring session, you usually see type 1 diabetes at a younger age, and you usually see type 2 diabetes in an older age. Why that makes sense is because in type 1 diabetes, it's speculated to be caused by an autoimmune disease. So that's something that might be present, at early stages of life. So that's why you would usually see younger people that have type 1 diabetes. And type 2 diabetes, even though we see a higher incidence of children that have type 2 diabetes now, type 2 diabetes was usually associated with adults. Because again, you need that constantly high blood glucose in order to get type 2 diabetes. So again, type 1 we usually see in the younger age group or the younger age patient population, whereas type 2 diabetes we usually see in not necessarily the older adult population, but we see in the adult population. Who did I have for N120? I had Professor Sarkisian. Yeah, no problem. Exercise, ketones, and type 1. Okay. So a really important thing that we might see in type 1 diabetes is diabetic ketoacidosis. Does anyone know what diabetic ketoacidosis is? It's okay. Okay, so ketones are released into the bloodstream. That's good. So why do you think, if you have any idea at all, why do you think ketones are released into the bloodstream with diabetes type 1 specifically? Going back to patho, if you can recall. Okay, it's somewhat related to fats. So pretty much. Oh no, you're fine. I just again um just let me know if how I go about my tutoring sessions bothers you guys, but I kind of like to ask questions because I think it's beneficial if the people that come to my tutoring sessions can recall it from their own, from their own bank in their mind. Because I think it's just again, if I just lecture to you guys, I feel like it's very stale if I don't ask questions. But there's no shame. I don't I'm not what's wrong with you, that's why I'm here, you know. So with diabetic ketoacidosis, right? Pretty much the whole mechanism behind it is that when your body's starved of glucose, what your body might do is they might make a replacement for that glucose. So it's kind of confusing because in type 1 diabetes, with any diabetes, you have high blood sugar, right? But the reason your body makes keto acids, even though you have that high blood sugar, is that, remember, the problem is that your body's not making insulin at all in type 1 diabetes, right? So if your body's not making any insulin at all, then that glucose that's inside the blood, that's very, very high, can't go into the cells to lower blood glucose. So what your body does, it makes an alternative source of fuel through keto or ketones or keto bodies, right? And those keto bodies are those are the replacement for the glucose that can't go into the cell because of your lack of insulin production. Does that make sense? I know it's a lot, but if I complicated it, I can try to simplify it. Fats of the made by the liver from breakdown of fats. Yeah, exactly. I was just relating it to your point in that, you use alternate source or you use alternate macronutrients such as fats and proteins, exactly, to make those keto bodies, which are which are the glucose replacement in terms of fuel. Glucose isn't being broken down, so the next best thing is fat. Exactly. Yeah, you can't use the glucose, so what you do is break down that fat to make that alternate fuel, which is in the form of ketone bodies. Does that add up, you guys?
Yes, thank you.
Yeah, no problem. No problem. Okay. So going back to that, right? You have diabetic ketoacidosis. And again, with that, a lot of people that have type 1 diabetes don't know they have type 1 diabetes until they have a crisis, such as ketoacidosis, right? So the patient that has diabetic ketoacidosis, they may come in with certain signs and symptoms. Can any of you recall certain signs and symptoms associated with diabetic ketoacidosis, particularly their breath? How would their breath smell with diabetic ketoacidosis? Exactly. Their breath would smell sweet if they're in diabetic ketoacidosis. Let's see. And that's like one of the big telltale signs that they're in diabetic ketoacidosis. Okay, moving on, you guys. Can anyone recall the normal blood glucose level? Yeah, fasting. Sorry about that.
I believe is less than 130 or up to 130, or is it
Oh, go
or is
ahead.
that pre-diabetes? Is it?
Yeah, you're pretty much there. So the normal range is 74 to 106, right? And then the pre-diabetic range is I think 106 to 125. And above 125, you would be considered in the diabetic range. So again, just to repeat the values, 74 to 106 is normal blood fasting blood glucose. Dun, dun, dun. HbA1c. Okay. Can anybody tell me what is HbA1c and the significance of that test? HbA1c.
It gives you a range of, I think, up to 3 months of how the body is managing the glucose levels.
Exactly. So why does it make sense that with HbA1c, you can have this test last or be relevant for 3 to 4 months in terms of monitoring blood sugar? Why does that make sense? If you have any idea. Exactly, hemoglobin, right? So with hemoglobin, remember blood cells, they live up to 120 days. So in terms of months, that's 4 months. What HbA1c is pretty much your glycosylated hemoglobin, right? It pretty much detects how much hemoglobin has a glucose associated with it, right? And what HbA1c is good for is that when you look at HbA1c, you can kind of see how the patient's dietary patterns have been, right? Because those blood cells go all the way back to 4 months. So obviously, if the patient is, let's say you already do their HbA1c and it's above the normal range, which is 6.5 and below, right? Let's say it's at 10% HbA1c, right? And we assess the patient. We do, our patient assessment. We ask our patient questions during their physical exam, and we're like, how have you been, have you been compliant with your diabetic diet? Have you been getting exercise? And they express, oh yeah, like I have been getting exercise, I have, been eating and complying with my diabetic diet. Then we can have that HbA1c kind of as like, not necessarily evidence, but more, okay, even though you might not be as compliant as you would want to be with your diabetic diet, like you can see the progression of the patient's ability to comply with their diabetic diet and their lifestyle interventions by looking 4 months back from that whole time period, if that makes sense. Any questions on that, you guys? HbA1c? Okay.
So only one.
Mhm.
So you were saying 6.5 and below. Is that only for a diabetic patient, or is that in general for everyone?
Okay. I'm honestly not sure about that. Um, I think in terms of preparing for your quiz, I don't think you have to know that specifically, but just know 6.5% is the magic number.
Okay.
Sorry about that.
No, that's okay. It's just me, my brain
Oh no,
overworking.
no, that's great. Like, dude, be curious. It's like one of the best things you could do for yourself for this program. Seriously.
Okay.
Okay. So if a patient has diabetic, if a patient is diabetic, what are the 3 P's associated with diabetes?
Polyuria.
Oh wait, sorry.
You asked for 3 P's. 3 P's.
Mm-hmm.
Oh yeah.
Mm-hmm.
Polyuria.
Yeah, polyuria.
Yeah, one of them.
Yeah.
I heard about 3 P's, but I'm not sure which.
Oh no.
Exactly.
It's fine. Like, yo, throw stuff out there, you guys. Okay, polydipsia, polyuria. One more. Polyuria, polydipsia, polyphagia. Woo! Let's go. Okay. So what is polyuria, you guys? Anybody? Increased urination. Yes. Polyphagia? Yes, increased hunger. And polydipsia. Oh shoot, exactly. So why would these make sense? Let's start with polyuria, right? Oh no, it's okay, you're fine. So with polyuria, right, you have so much glucose in your blood that what your kidneys are going to try to do is that they're going to try to excrete this glucose, right? Because it's like, yo, why do I have all this glucose in my blood? Like, I got to get rid of this stuff. And what they do is that the kidneys get rid of that excess glucose through, through forming urine and depositing that glucose in that urine. And that's why you see when patients that are diabetic, they might have a sweet smelling urine because of that glucose that's being filtered out of their blood, correct? So, um, I don't know if any of you learned this concept in pathophysiology, but when you have a high concentration of solutes, right, such as glucose, such as sodium, etc., right? Water is likely to follow those solutes, right? Water follows sodium. Water also follows glucose. So if you have a lot of glucose excreted from your or excreted in your urine, water is likely to follow because glucose is like such a big um, nutrient in the body that water just follows that solute, glucose, right? So that's why you have a high amount of urine. That's why you're constantly urinating if you have diabetes, because you're constantly having a high volume of urine production because that water is following that glucose that's being excreted. Polyphagia, right? It's interesting because it's like, okay, we have a bunch of glucose in our bloodstream. Why would we feel starved, right? The reason we would feel starved is because, again, diabetes is a problem with insulin. And with insulin, we need insulin to take glucose into our cells. If we can't take glucose into our cells, such as with diabetes, our body's gonna feel starved and we're gonna feel like, yo, like, I don't have any energy, like, I need to eat because no glucose is going exactly. Yes, the cells are starved. And that's why you're constantly eating because your cells kind of have this, it's not necessarily an illusion, but they have this idea that they're starving because no glucose is coming in, when in fact there's such an abundance in the bloodstream, but the insulin's not there to bring it into the cell. Exactly, no energy. So we've covered polyuria and polyphagia. Can anyone take polydipsia for me? Any takers? Polydipsia?
I'll take it.
Let's go.
Okay, so the excessive thirst is because the glucose levels are so high that is it thickening the blood? Is that what's
Mm-hmm.
happening? And then you're getting thirsty just because your body's trying to compensate?
Mm-hmm. Yeah, pretty much. So like it's kind of similar to when you have too much sodium in your blood, right? Again, sodium is such a big um, mineral or electrolyte in terms of like fluid balance. So when you have too much sodium in your blood, what is going to happen to your body is that all the blood, or not all the blood, but all the water from your interstitial and your cells, they're going to go into your bloodstream because you just have a high sodium level. And again, what your body is trying to do in that is that it's trying to pretty much get the sodium concentration to a normal level, right? Because it's so saturated that it's trying to drop the sodium level. It's a similar thing with glucose, as you mentioned, Chelsea. Your body is just so, not your body, I'm so sorry, I'm misspeaking. Your bloodstream is just so filled with glucose that what it's trying to do is it's trying to pretty much equalize that concentration in the blood, right? And that's where you get the sense of thirst, and that the water from the cells and the water from the interstitial is being drawn into your bloodstream to normalize that glucose concentration. And that's why you're going to feel that constant sense of thirstiness, of wanting to drink water, because your cells are not only starved because of the lack of insulin, your cells are dehydrated because of the water being drawn into the bloodstream. So do the 3 Ps make a bit more sense now, you guys?
Yes.
Woo! Let's go. Okay. Any questions, you guys? 3 Ps. For sure. No problem, no problem. Okay. Can anyone explain secondary diabetes? Or does anyone have any idea of what secondary diabetes is? Okay. So you guys have done your, obviously I would think even though we're virtual, I think you guys have still done like your care plans and everything, right? Like your nursing diagnosis, blah, 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 like, oh, acute confusion related to blah, 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 secondary to blah, blah, blah. So remember, in that nursing diagnosis, we say secondary to. What secondary to basically means is that that problem is a result of another big problem, is a result of this or that, correct? What secondary diabetes is, and I have like a good example for it, is diabetes that's not necessarily due to insulin per se, but diabetes that is secondary to, so a result of another disease. So one good example of secondary diabetes is Cushing's syndrome leading to hyperglycemia. Does anyone know what Cushing's syndrome is? Any takers? Going
It
once.
has something to do with like excess cortisol.
Yeah, exactly. And if you have too much cortisol, what does that do to your blood sugar?
Would it raise it?
Mm-hmm. Exactly. And that's why you would have that hyperglycemia. Also, that you would have that hyperglycemia that appears as diabetes, correct? So it's different from diabetes type 1 and diabetes type 2 because diabetes type 1 and type 2 is due to insulin, right? Whereas secondary diabetes is secondary to another disease, such as the example with Cushing syndrome, leading to more cortisol production, thus keeping your blood sugar constantly elevated. Does that add up, you guys? Okay.
Yes.
For sure. Sorry, I want to make sure that nothing kind of slips through the cracks, but I'll stop asking. If you guys have a question, just throw it out there. Inspect the feet. Ooh, okay. So, why would we want a diabetic patient to get foot care from a podiatrist, so a foot specialist? Why is that?
Because of neuropathy problem and sensation, like they cannot feel any abnormality on their feet.
Mm-hmm. Exactly, because of that nerve damage caused by the diabetes, right? So in addition to having a podiatrist do the foot cleaning for the patient, We also want to instruct the patient to inspect the feet daily because again, they might have that neuropathy, and what that neuropathy does, it decreases their sensory perception. So they might not feel that they have a foot that is gangrenous or infected, etc. So what we want them to do is we want them to inspect their feet daily. Registered dietitian, demonstration to one. Okay, you guys. So usually when we give insulin, we give it before meals, correct? Why do we want to assess if the patient is willing to eat before we give them that insulin before meals?
You're saying that why the insulin before meals?
Oh, no, sorry. To clarify, why do we want to see or why do we want to ask the patient, are you willing to eat before we give them insulin?
Oh, because the insulin would help them from eating, the glucose goes up. So the insulin is there to help with that. If they don't eat, then they can go into hypoglycemia phase.
Exactly. There we go. That's why we always want to assess the patient's hunger, the patient's appetite before we do administer that insulin. Again, even though it is, it's just standard practice to give insulin before meals, we want to make sure that the patient is willing to eat so we don't bottom out their glucose. Okay. So let's say that we do slip up, right? Let's say that, okay, we didn't assess if the patient is willing to eat, we still give them that insulin, and they don't eat a drop of their food, right? And then we look at their blood sugar, and then we see that their blood sugar is at 40, right? If the patient is still awake, what do we give to that patient?
You can give them some juice to
Mhm.
get their sugar up, or
Exactly.
maybe like carbs, simple carbs.
Mhm. Yeah, exactly. So things such as orange juice, that's like the standard thing. You might also want to give them glucose tablets, if those are available as well. So after you give that, you want to make sure to recheck their blood pressure, no, not blood pressure, their blood glucose 15 minutes after you administer that form of carbohydrate, such as orange juice. And when you recheck, you want to be able to have 2 normal blood glucose levels, correct? So let's say you recheck at 15 minutes, right? And then the patient's blood glucose level is 86. That's in normal range, right? But then, 15 minutes later, they drop back down to like 60. You want to give them glucose until their blood glucose levels stabilize, right? So let's say the patient is, a similar scenario. We go into the patient's room, we messed up, we gave them insulin despite them not having an appetite at all. We go into their room, they have a blood glucose of 50 and they're unconscious. Instead of food, what can we give them?
Isn't it D50 or something like that?
Mm-hmm.
Through
Dextrose,
IV?
exactly. Dextrose 50% IV push, right? Because we want to raise their blood sugar now because right now they're in a critical condition, right? What is a hormone we can give them? It's the opposite of insulin. Mm-hmm. Exactly. We can give them glucagon to try to raise their blood sugar. So again, just to recap, if a patient is hypoglycemic and they're alert, give them orange juice, give them some sort of food carb, right? Assess their blood glucose every 15 minutes. If they're unconscious, dextrose 50% or glucagon. Okay. Is anyone willing to explain how to mix regular insulin and NPH insulin?
First regular and then NPH.
Okay.
But
So,
for the air,
uh,
first for NPH and then regular because we cannot mix
Awesome. So just to recap, I'm sorry if I'm mispronouncing your name. Sogan?
Yes.
Okay. I'm not mispronouncing it, right?
No, you're right. So again.
Okay. No problem. Okay, so imagine this is NPH, my ID, and this is regular, a highlighter, right? So what you're gonna do first, oh wait, I need another thing for my syringe. Pen is syringe, this is NPH, this is regular insulin, right? So let's say there's 20 milliliters I have to withdraw from the NPH insulin, right? Or yeah, correct. What I'm gonna do is I'm gonna aspirate 20 milliliters of air in my syringe, and then I'm gonna inject that in the NPH vial here, right?
Right.
After I do that, let's say I have 10 milliliters of regular insulin in here, correct? I will aspirate 10 milliliters of air, boom, inject it into the regular. So we have NPH and then regular. And now when it comes to taking up the insulin, correct? So actually getting the insulin from the vials, now that's where the opposite kind of happens. Instead of taking the insulin from the NPH vial first, in which we injected the air into first, we're taking it from the regular now. So we draw up 10 milliliters of the regular, and then after we draw up the 10 milliliters of the, or after we withdraw the 10 milliliters of the regular, we're withdrawing the 20 milliliters from the NPH. So a good acronym to remember that, you guys, is remember Nancy Reagan RN, NRRN. Inject NPH, inject regular, aspirate NPH. Okay, you guys. Are there any, what is NRN? Okay, I'll type it in the chat. Inject NPH with air. Inject regular with air. Aspirate regular. Aspirate pH. Does that make sense, Pita? Or Beta? I'm so sorry, I'm not great with names.
No, I find it. Thank you so much.
Okay, no problem. Okay. All right, you guys.
Okay, so
Oh,
first
go-
so we inject air into the NPH first,
Mhm.
then the regular, then we aspirate the regular, and then aspirate NPH. Isn't it another thing where it's clear to cloudy?
Mhm.
At first
Yeah.
people say.
Yeah. Because, oh, go ahead.
How does that go? Clear to cloudy, or I don't remember how it goes.
No, you're good. So, um, this is where it can get kind of confusing because it's like all C's, whereas NRRN, Nancy Reagan RN, could be more clear. You know, it's like you're still going to the same location, but you're just doing it in different ways. But pretty much the cloudy to clear thing is you inject air into cloudy, which is the NPH, you inject air into clear, which is the regular, and then you aspirate clear, which is regular, aspirate cloudy, which is NPH. And if I remember correctly,
Okay, I'm just gonna use your first one.
all good. Oh, let me think. Nancy Reagan, RN. There you go. Yes, and you always inject the same amount of air you are aspirating, correct? Genoveva. I hope I said that right.
And you said how much air do we inject into it?
You inject, oh, Jen is fine. Okay, I'm so sorry. We inject how much air we have to aspirate out. So let's say there's 20 milliliters of NPH we have to get out of the vial, right? Then we would inject 20 milliliters, right? So let's say there's 30 milliliters in here. We would inject 30 milliliters of air. Let's say there's 50 milliliters in here. We would inject 50 milliliters of air. Let's say there's like a gallon of NPH. We inject a gallon of air into here. So it's just pretty much the air you inject is just equal to the amount you would draw out.
Okay, thanks.
Of course, no problem. Mm-mm. Okay, so just a note, you guys, if you ever have to give insulin, make sure that you have another nurse to verify your insulin. Because again, insulin is a very high risk med because it could bottom out the patient to make them hypoglycemic. Exactly, a second witness. So make sure to hit up your fellow nurses if you ever need to administer insulin. Let's see what else. Okay, you guys. So as I mentioned, you could give the patient insulin. I don't know if your professors have covered this in class, but you can also give, anti-diabetic drugs such as metformin, etc., some sort of, not necessarily insulin, but a glucose controlling drug. But let's say the patient, is just like, screw these meds. Like, these meds suck. I don't want to take these meds anymore. What can we suggest to the patient to try to help manage or lower their blood sugar?
Exercise, right? I mean,
Yeah,
yeah,
exercise.
exercise and dieting.
Exactly. Those are the two big things, right? Because exercise, it can mimic the action of insulin. It can work in a similar way as in when you exercise, what it does, it brings glucose into your cells, right? So that's a great thing we can do for them because not only will that lower their blood sugar, exercise makes people feel better. Like with me, sometimes when I'm short on time with my exercise, like I just take a 30-minute walk and I'm like, wow, life is good, you know what I'm saying? But it also brings up their mood and it lowers their blood sugar at the same time, and we could also suggest nutrition changes. We could suggest a diabetic diet. Of course, a patient might not be willing to be compliant with it, but we always want to let them know that they have options, and they don't always have to go to the meds as their only intervention. Let's see, what else? Okay, you guys, I'm referring to something I mentioned earlier in my tutoring session, but again, remember with patients that have type 1 diabetes, they can have episodes of diabetic ketoacidosis, right? And with the term diabetic ketoacidosis, we have the word acidosis, right? Acidosis pretty much indicates that we have an abundance of acids in our blood, right? So if we have too much acids in our blood, why would it make sense that we would have Kussmaul respirations in a patient that has diabetic ketoacidosis? Kussmaul respirations. Does anybody have a guess?
No, but I have like metabolic acidosis here. But
Wait, you have metabolic acidosis?
like I don't know why I put an arrow and then I put metabolic acidosis.
Oh, okay. Sorry. I was just like, do you have it right now? Like, do you want me to call an ambulance?
Oh no.
You're fine. Yes, as Jen had said, it is respiratory compensation. So I think you guys covered this briefly in your fundamentals class. But what happens when you have a bunch of acids in your body that are due to a metabolic process, such as, diabetes type 1? What your body's going to try to do is it's going to try to excrete as much CO2 as it can, because CO2 works as an acid in the body. And remember, the body is already very acidic because we have that diabetic ketoacidosis causing that abundance of keto acids, right? So what your body's going to try to do is it's going to try to get rid of as much CO2 as it can in order to normalize your pH. So that's why you have the Kussmaul respirations, the deep and rapid respirations, right? Because you're trying to get rid of as much CO2 as possible in response to diabetic ketoacidosis. I hope that makes sense. Okay. Retinopathy, check feet, observation. All right, you guys. So I think I covered the bulk of what's important about diabetes. Oh, HHS is for type 2, but what is it exactly? So hyperglycemic hyperosmolar syndrome, right? Remember how I mentioned your body has that polyuria? Or not polyuria, excuse me, polydipsia? So hyperglycemic hyperosmolar syndrome, the answer is in the name. You have too much glucose, hyperglycemia. Hyperosmolar, your blood is it has hyperosmolarity. So it has that really high glucose concentration, thus drawing in the water from your cells. And then syndrome, as in just describing that this is a thing, increased blood osmolarity. Yes, oh my gosh. Nice. Does that make sense, Project? Woo! Let's go. Okay. Does anyone have any more questions about, diabetes or just anything related to that before I move on to GI?
My teacher, she mentioned macrovascular complications of diabetes and microvascular
Mm-hmm.
complications.
Mm-hmm.
Can you, I mean, what do we need to know? Like what exactly each complication is? Because I wrote down like cardiovascular disease,
Mm-hmm.
which is the risk factors would be like smoking and also that physical activity helps with that.
Mm-hmm.
That's all I put for that, but I don't know if there's just something else that you can.
Okay. Again, this is like, thank you for asking. It's just like, again, it's just different with different professors, and my professor didn't cover it, but I can still kind of give you my input on it. Like, I just want you, like, I just want to put a disclaimer out there that this wasn't something that was lectured on, but I can give you what I think the process is, if that's okay with you.
Yeah, that's fine.
Okay, no problem. So I don't know the exact mechanism of action, but I think over time, what diabetes does is that it damages your vasculature, right? I don't know if it scleroses it, I don't know if it hardens your arteries, but over time, it affects your vasculature in a negative way, right? And that's why, as Jen mentioned, you would have that retinopathy, neuropathy, or well, yeah, I could see neuropathy playing into it too, because obviously, like, your neurons need a blood flow as well. But that's why you see that retinopathy, the neuropathy, and also that nephropathy, right? Because you have damage to your blood vessels, and that's what's causing the diseases such as retinopathy, neuropathy, um, and nephropathy. Because you just have, again, that damage to your vasculature as a result of that those constantly elevated glucose levels. I'm sorry, I wish I could give like a bit more on it, but I think that's like all I can really get out of like my own reasoning of it.
Okay, that's fine. Thank you so much.
Of course, no problem. Any more questions, you guys, about diabetes? Again, I'm okay. Again, I'm sorry if I don't cover everything, and if I don't have like a straightforward answer with the question. I just we'll figure it out together. Let's see. Is that the only
Bye.
thing that's enough for endocrine? Oh, excuse me?
Jackie.
Wait, sorry. What?
Huh?
Oh, did he say something? Chris?
Oh, sorry. No. Sorry,
Oh,
talking to my
no,
parents.
no,
I'm
it's
so
fine.
sorry.
No,
I meant to be muted.
Oh, no.
Awkward.
No, you're fine. Don't worry. What's up, Chris? Hi. You're fine. Okay. So let's see. Any questions? Okay, you guys. Speak now or keep your peace. Okay, moving on to gastrointestinal. So LMAO, my last question. Oh, sorry. Is that the only thing we need to know for endocrine? Yeah, I think diabetes. Who's your professor, Jen? Rosas. Did she lecture on anything other than diabetes? Jen? Oh, she.
Well, my teacher, she ended up talking about where is it? The metabolic syndrome.
Metabolic syndrome. Okay, for sure.
She went over.
Okay. Let me see. I'm trying to recall. Cushing's, Addison's. Okay. Hyper and hypothyroidism. Okay. So I could briefly cover Cushing's and Addison's, what they are, and I could explain what you would see with hyper and hypothyroidism, and I could give a little bit on metabolic before we go on.
Okay.
So Cushing's, you pretty much just have an excess of cortisol, right? And your adrenal cortex, for some reason, is producing too much cortisol, right? One way to remember this is that Cushing's, right? Cushing, you're kind of cushioning. The patients that have Cushing's, you might see that they have a moon face or a buffalo hump. So they have that extra fat deposition, exactly. They have that extra fat deposition in their face or kind of like on their upper thorax area, correct? But not upper thorax here, but you know, the buffalo hump in the back, correct? So with hypercortisolism, again, it's due to your adrenal cortex for some reason producing too much cortisol, leading to those characteristic signs and symptoms such as too much, or not too much, but excessive fat deposition in your face and your back. In Addison's, just think it's the very opposite of Cushing's. And another good way to remember Addison's is that you have to add more cortisol. You have to add more cortisol because you have low cortisol secretion, right? I can't recall the specific signs and symptoms right now. Let me take a look-see. Let's see. Which one can't have potassium? Did your profession, or I know you're asking me this, but can anyone recall which okay, Cushing's. Do you have, because hyperglycemia. Sorry, Jen, do you mind that I ask you if you like have a rationale behind it? I just want to know, like, for, you know, for like, I don't know, I think I'm forgetting something. Okay, for sure. Honestly, Rajiv, I'm not completely sure myself in terms of which one can't have potassium. Oh, my question was, do you know why patients with Cushing can't have potassium? Okay, it's no problem. Okay, so again, Rajiv, I'm not sure which one can't have potassium, but like, thank you, Jen, for putting, you know, that out there. No problem. I'm sorry about that. Okay, so again, Addison's, you just have a lack of cortisol production. No, you're fine. I mean, again, like, oh, it might be the opposite. Oh shoot. Let me search it. Cushing, Addison's. Okay, for sure. So would it be the opposites Gamo used to say in his class, but I can't recall. So for Addison's, do you just have that lack of, or you have too much potassium? No sodium, potassium. Okay. So what I see right now is that in Addison's disease, you have a low sodium but a high potassium level, right? So I think in Addison's, you have hyperkalemia. Oh, okay, for sure. Yes, teamwork makes the dream work. Thank you guys. You guys, no, it's okay. Thank you. Okay, so to answer your question just based off my own knowledge, Rajiv, Addison's, you don't give potassium. So no potassium for Addison's. Thanks, Jen. Thanks, all of you. Okay, yes. So Addison's, you don't give potassium, and that's because you have hyperkalemia. And again, Addison's is when you have low cortisol. Cushing's is when you have high cortisol and you get the moon face and the buffalo hump. Okay, so let's see. So with hyper and hypothyroidism, can anyone recall what the function of thyroid hormone is?
Makes, I guess, a reaction on your metabolism, whether it's hyper, excessive. I guess increased metabolism, hypo would be decreased metabolism.
Exactly. So it just lines up with the word, right? Hyper, boom, 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 boom. You have a super high metabolic state, right? So you might see patients that have heat intolerance because, again, their body is just like boom, 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 metabolic reactions, right? You might see that they're too hot. You might see that they can't gain weight at all because, again, their body is just constantly running their motor. It's constantly going, right? But with hypothyroidism, it's the exact flip, right? They have cold intolerance because their body's not constantly working. The engine's not constantly going, burning fuel. And that's why they have that cold intolerance. Okay. So pretty much what you need to know with hyper and hypothyroidism is that hyper, increased metabolic rate. Hypothyroidism, decreased metabolic rate. Production of T3 and T4. Yeah, exactly. So hypo, low thyroid hormone, low T3, low T4. And hyperthyroidism, high T3, high T4. Does that add up, you guys? Hump. Does it? Okay. Thank you. I was like, this is gonna be like my awkward tutor moment. I can't, like, someone please respond. Okay. Let's see, what else is there? Hyper and hypothyroidism, Cushing's, hyperglycemia. Okay, awesome. Any more questions about endocrine? Anybody? Okay, for sure. Moving on to GI. GI. Okay, you guys, back to your funds knowledge. How do I assess the GI? In what order do I assess the GI in terms of inspection, percussion, auscultation, and palpation? What's the first thing I do in that order? I inspect, I auscultate, percuss, and then palpate. Why do I go in that order instead of inspecting, percussing, palpating, and then auscultating?
Because you can stimulate paralysis. Oh, no, wait, not paralysis. Peristalsis?
Yeah, peristalsis.
Yeah, that.
There we go. Peristalsis. You can stimulate peristalsis, giving that false sense of the patient has normal bowel function, right? And that's why we auscultate at the very end, because we don't want to get inaccurate results when we assess, correct? So, moving on. When let's say we're going to do some sort of diagnostic visualization test, correct? And so, there's an order for a barium test or a barium swallow or possibly a barium enema. What that is that we give a patient a dye to swallow, or we want that dye to go in their GI system. And what that dye does is that it colors the colon a white color, right? So let's say the patient they'd never had a barium test ever before. What is one patient teaching that we want to provide in terms of the barium test?
We want to ask them if they're allergic to iodine.
Okay, that's good. That's good, but in
Um,
terms of their bowel movements, what is
oh,
something
okay.
we want to teach them?
Mm,
Changing the color of the bowel movement. If
Uh-huh.
if the color of the bowel movement change, like feces change.
Exactly. So if they get a barium test, we always want to provide patient teaching with any procedure, correct? Because we don't want to leave patients in the dark. We wouldn't even want that for ourselves. So again, we teach the patient that, hey, I want you to know that your stool might be light colored, but I want you to know that that's normal, and that's just an indication that the dye was injected correctly. Because again, the barium test colors the colon white, right? If it colors the colon white, it makes sense that they would have a light colored stool. Upper GI, nausea, vomiting. Okay, so let's say a patient is straight post-op, right? Like they legit just had, I'm trying to see a procedure that's relevant. No, okay, it could still work. Let's say they just had a hip replacement, right? A total hip arthroplasty, correct? One consideration we want to definitely consider when a patient is post-operative is that the patient might not have any peristalsis or any bowel movements because of their anesthesia, right? So obviously, what do we want to do before we give the patient any food at all? Any food at all with any surgery?
check for gag reflex.
Yeah, that's important. But in terms of their bowel, like in terms of their peristalsis,
You want to make sure they fart first, I guess.
we want to make sure they have bowel sounds. But we want to make sure they fart too, because that's an indication of bowel sounds. Were you just gonna stand there and listen for the fart sounds? I'm just kidding. I'm just
Maybe.
kidding. I'm just kidding, Stephanie.
That was funny, Stephanie.
That was a good one. That was a good. I'm gonna save that one. I'm gonna save that one for next term. Okay, so yeah, obviously we want to see if they have any not bowel movements, but any peristalsis of sorts, as indicated by the passing of gas. They don't have any bowel movements after a major surgery for a day. Okay, I don't think that is a set in stone time period. I think it's just variable because again, it depends on the surgery you have, the type of anesthesia you use. It's just so many factors that play a part into their bowel movements. And I'm pretty sure, if any of us were to be in the perioperative setting for abdominal surgery, I'm not entirely sure.
You said check for this before we give them any types of food, right?
Exactly. Because we don't want them to have any bowel obstruction, or we don't want the food to just sit in their stomach. They're at risk for aspiration at that point if they lay down, right? And they're also at risk for aspiration too if you give them food and you don't check their gag reflex. But to answer your question, Rajiv, I'm not sure the duration in terms of bowel movements, or in terms of a lack of bowel movements after abdominal surgery. Do you have, I think you said you had rosis, correct? Okay. Did you have Rosas? Or do you have, oh, Garcia? Okay. Do you remember her saying anything about the duration?
No, but I think it was a question in our. We had a question in one of our practice quizzes, and it was like a question worded that way. One day after a major abdominal surgery, expect no bowel movements or bowel sounds for like a day.
Wait, I'm sorry. So you had seen this question come up um, a day
In a
post-op.
practice quiz.
Okay, okay, sorry. Do you mind repeating the question again?
I forgot what the question was, but the answer was expect no or little to no bowel movements or bowel sounds one day post-op after a major abdominal surgery.
Okay, for
I,
sure.
I'm in her class too, and I know what I wrote down in my notes was for the PEG,
for the percutaneous endoscopic gastrostomy, it says nothing by mouth before and after. And then it says for after, she had said 24 to 48 hours after tube placement is when the feeding would start. And that's when she said you'd need to have gag reflex to be okay and all of that. I don't know if that's what you guys are referring to.
Well, it's all good. We can just go over this or skip it.
Okay. Yeah, I'm sorry, Rajiv. Again, I'm not sure of the duration, but I would say definitely look through, or if you can go back to that question, or not you can go back to that question, but I think that's definitely a good thing to note, because again, that just builds on the concept of you want to check their bowel movements or their bowel sounds before you initiate any feeding. Okay. No problem. Okay, so let's say you work in the urgent care or emergency department, right? And the patient complains of heartburn. What is heartburn an indication of? GERD. Can anyone tell me what GERD is?
So gastroesophageal reflux disease or disorder.
I mean, like what happens in GERD? Stomach acid backflows into the esophagus. Exactly, and that's why we would see that acid go, or due to defect in lower esophageal sphincter. Oh my gosh, yes, dope. Okay, so pretty much what GERD is that you have dysfunction. Oh, were you gonna say something? Sorry. Okay, I guess I misheard. Okay, so what happens is that you have problems with your lower esophageal sphincter, right? So normally when you have normal function with your esophageal sphincter, you shouldn't have that reflux of acid back into your esophagus, right? And because you have that problem with the esophageal sphincter, right? Because you maybe have that loss of strength, that loss of tightness of the esophageal sphincter, you have that acid that was just chilling. Is this my stomach? You have the acid just chilling in your stomach, shoot right back up your esophagus. And that's why you get pain in kind of like the sternal area or the heart, thus producing the heartburn, because that acid is refluxing back into the esophagus. So before we consider any pharmacologic interventions, right? What can we do for a patient with GERD? First of all, how do we position them once they eat?
Upright?
Yeah, flowers. Or
Upright?
flowers.
Wait, sorry. Sagan, you're right. Upright? What were you saying, Stephanie?
Flowers or
Oh, sorry. I thought you said flowers. Yeah. You would position them in the high Fowler's position. Correct. Because again, the issue is that their esophageal sphincter is dysfunctioning, right? If you lay them flat, obviously that acid is more likely to reflux back, right? If you have them in the high Fowler's, I would say just high Fowler's is your best bet if it's not contraindicated, because that decreases the likelihood as much as you can, you know? So you want them in high Fowler's, you want them upright, because again, you don't want that you don't want that acid to reflux back into your esophagus. Okay. No fat diet. In terms of diet, what type of diet do we want them to consume?
No caffeine, no acidic food, like orange juice maybe.
Yeah.
Tobacco, smoking, no smoking.
Yeah.
Yeah.
No irritating foods, right? Because that might cause more gastric acid production, right? No tobacco, no caffeine, low fat diet, etc. So a non-irritating diet, right? Okay, you guys. So I know you guys, wait, oh shoot. Sorry, I remember that not, I remember microbiology is not a requirement, or not, it's not required to be taken at the university. But going back to that, if we have peptic ulcers, what is the main pathogen behind peptic ulcers? Like, what's the main infecting agent for peptic ulcers?
It is something, oh yeah, H.
Pylori.
Uh-huh.
H. pylori.
Yeah, H. pylori.
Helicobacter pylori.
Well said. Well said. Helicobacter pylori. So with that, what it does is that bacteria, it erodes at the gastric mucosa, right? Causing those peptic ulcers. What's one medication, if we take this chronically, if we take this constantly, that can cause peptic ulcers?
NSAIDs?
Mm-hmm. NSAIDs, correct. Have any of you discussed NSAIDs in your pharm class? Okay.
Yeah.
So the words COX-1 and COX-2 are familiar, correct?
No, not yet.
No.
Oh, okay, for sure. So pretty much just know that NSAIDs can cause peptic ulcers. COX-1 and COX-2? No, you're fine. COX-1 and... Oh, you've heard of it? Oh, okay, for sure. So if you're willing to share, why can NSAIDs cause peptic ulcers? Knowing that NSAIDs affect COX-1 and COX-2. If you have any guess or any idea. Kind of. You're close. You're on the right track. So COX-1, what it does, you pretty much have this type of mucus. No, you're fine. You're good. You were like, dude, like you're right there. You're right on track. So pretty much with COX-1, that is an enzyme that's responsible for the production of mucus in your GI or in your gastric lining, right? And that's super important because that prevents the stomach from auto-digesting itself. So you have gastric acid secretion, right? You have, I think it's hydrochloric acid is the acid that's secreted in the gastric system. But you also have this protective mucosa. And mucosa, right? Mucosa produces mucus. So that mucus covers the stomach lining. And what that does is that it prevents the gastric acid from eroding the stomach. So that's why if you have an NSAID, you're constantly taking NSAIDs, especially ones that affect COX-1, then that gastric production of mucus won't be as protective or as prevalent, causing that stomach acid to break down your gastric lining even more. And that's why you get those peptic ulcers. Exactly. NSAIDs have COX-1 inhibition. Okay. So pretty much big things that can contribute to peptic ulcer development is H. pylori and NSAIDs, right? Some other things that can contribute to peptic ulcers are caffeine consumption and tobacco consumption. Peptic ulcers. Okay. So does anyone know why a peptic ulcer, why that can lead to possible peritonitis? First and foremost, what is peritonitis, if anyone can recall?
Infection of the peritoneum.
Exactly, infection of the peritoneum, right? And what is your peritoneum? It's your abdominal, it's like the, oh, go ahead.
Yes.
Yes, it's the mucosa that covers your abdominal cavity, right? And obviously your stomach and your intestines are in your abdominal cavity. So if you have breakdown of your, intestinal mucosa, your gastric mucosa, due to that H. pylori digging down, then what can happen is that if it progresses so much and it's not treated at all, it might burrow down so much that it causes an opening between your stomach and your peritoneum. And that's an emergency. That's a crisis because, again, the peritoneum is sterile. If we have bacteria, which, the stomach and the GI system is full of bacteria, go into the peritoneum, we can have that infection of the peritoneum, so peritonitis, leading to possible sepsis, which is like a huge life-threatening situation for the patient. So that's why it's possible to get peritonitis if those peptic ulcers are untreated. Okay. So I think gastritis is pretty self-explanatory. Gastritis, it's inflammation of the stomach. You can see it with things that irritate the stomach, of course, like alcohol, spicy foods, H. pylori, and autoimmune disease that causes that inflammation of the stomach. And of course, since your stomach's malfunctioning, correct? It's inflamed. You might have anorexia, and you might also have an upper GI bleed because of that inflammation, right? So can anyone recall what the term pernicious anemia means? Pernicious anemia. Okay, so pretty much pernicious anemia, you have this thing called intrinsic factor, right? You have this thing called intrinsic factor that your stomach makes, or your GI mucosa makes, right? If you have damage to your stomach, you have damage to that GI mucosa, as seen with gastritis, right? So because of that damage to your gastric cells, because you have that damage to your gastric cells, you have dysfunction of the production of intrinsic factor, which is needed to absorb vitamin B12. And vitamin B12 is needed to make blood cells. And that's why you have that anemia, because your stomach's not producing enough intrinsic factor because it's damaged. So it can't absorb enough vitamin B12. The lack of vitamin B12 leads to the lack of red blood cells, causing that anemia. I have to ask for this one. Does that make sense? Okay, sounds good.
I'm sorry, can you repeat that one more time?
Okay, I got you.
Can you put in the chat what kind of anemia was that?
Oh, yeah, no problem.
Thank you.
And I'm just joking, you guys. I'm not like actually bothered by it. I'm just being silly because I don't know, I'm just ridiculous sometimes. But yes, pernicious anemia. So what happens is that in gastritis, you can have something called pernicious anemia. Pernicious anemia is due to a lack of intrinsic factor, and intrinsic factor is produced by your stomach. When you don't have enough intrinsic factor, you can't absorb enough vitamin B12. When you don't have enough vitamin B12 in your body, that's when you can't make blood cells, because blood cells need vitamin B12, right? So it's pretty much your gastritis causing lack of intrinsic factor, no intrinsic factor, no vitamin B12 absorption, no vitamin B12, no blood cells, anemia. Does that make sense, Rajiv?
Thank you.
Yeah, I got it. Thanks.
Yeah, no problem. Of course. Okay. So obviously, if a patient has acute gastritis, right? We don't want them to eat anything, or we don't want them to take anything by mouth because their stomach is inflamed. Like, we need their stomach to heal. So obviously we keep them rested, we keep them NPO, we monitor their hydration status, because again, they might be ordered to be NPO because they need their stomach to heal. So we want to make sure that, if we can't give them NPO, or if we can't give them oral fluids, we provide them some sort of hydration, such as with 0.9% normal saline. And yeah, pretty much the big thing is just we rest the stomach. And if, let's say the gastritis was caused by a poison, what we can do is wash out the stomach, so gastric lavage. Okay. So I'm just going to run through GI bleeding, right? So let's say a patient has hematemesis. Would we expect the bleeding to be upper GI or lower GI? Hematemesis, throwing up blood.
Upper GI.
Exactly, because that blood is fresh, correct? Let's say the patient has coffee ground blood in their emesis. Where would we expect that blood to be? Or where would we expect the bleeding to be if the blood appears coffee ground in nature? Well, not necessarily lower, but think your stomach, right? Because again, the reason you see that coffee ground blood is because you have that digestion of the blood cells in your gastric system, right? And because you have that bleeding in your gastric system, the gastric system is going to partially digest it. And that's why you have that coffee ground looking blood, because the stomach partially digests it. Okay. So let's say they have, okay, let's say instead of hematemesis, they have bloody stools. Is this an upper GI bleed or a lower GI bleed? Exactly, lower, right? Because it's fresh. If it was an upper GI bleed, let's say it was, more in the small intestines, more in the upper portion, then you would have that melena because that's old blood, right? And again, melena, what that is just dark colored stools due to dried and old blood being deposited in those stools due to an upper GI bleed. If you have a lower GI bleed, expect your stool to be, red in color, around that color area, because it's just a fresh bleed. Not a fresh bleed, excuse me, to correct myself. It's a bleed that's lower in the GI system, and thus you have that red color because it's lower in that area, and that's where stool formation occurs, right, in the lower GI system, such as the colon.
Okay, question.
Uh-huh.
If the stool is darker, it is upper GI bleeding, right? You mentioned. If it's like lighter, it's like bloody, it is a lower GI.
Yes.
Got it. Thank you.
Of course, no problem. Coffee color blood, that's pretty much from, okay. Coffee colored blood is if you have bleeding in your stomach or the blood reaches the stomach, right? And the reason you have that coffee, not coffee colored, but coffee grounds, it looks like coffee grounds in your blood. That's upper GI, specifically your stomach. Because remember, your stomach digests, it's responsible for digestion. So if you have that blood in your gastric acid, it's going to partially digest those blood cells. It's going to partially digest that blood. And that's why you get the coffee ground, right? Because it's partially digested. Does that make sense, Beta? Okay, no problem. Looks good, looks good. Okay. Perforation, peritonitis, distended abdomen. Okay, so let's say a person has peritonitis, right? When we palpate their abdomen, how is their abdomen going to feel? Is it going to be It's going to be rigid. I don't know exactly why, but just know if you palpate and you expect peritonitis, rigidness of the abdomen is a pretty good indicating sign. Give me a second.
Sorry, what was the question one more time?
Oh yeah, no problem. So my question was, if a patient has peritonitis, how would you expect their abdomen to feel upon palpation?
Thank you.
Oh, yeah, no problem. And just in case you missed the answer, it was rigid. Cats down, orthostatic hypotension. Okay, so let's say, let me see. Okay, so let's say a patient has a GI bleed. Why would it be a possibility that the patient has orthostatic hypotension?
Loss of blood or hemorrhage?
Yeah, Yeah, exactly. With GI bleeding, as I had stated. So again, they're losing blood. Remember, a thing that contributes to blood pressure is blood volume, obviously, right? So if we're losing blood through that GI bleed, it's a possibility the patient can have orthostatic hypotension, right? So how do we assess orthostatic hypotension, you guys?
We want to set the patient upright first, or wait,
Yeah, well, oh, go ahead.
let you go first.
Yeah, okay, so we have the patient lying down first, right? And then we assess blood pressure then. Then we wait a few minutes, and then we change the person to a certain position. We change them from sitting down or from lying down to sitting up, right? And then from there, we give some time before we take the next blood pressure. I'm sorry, I'm 100% not sure of the intervals between, lying down to sitting down or to sitting up to standing. But from the patient that's sitting up, we want to get them to a standing position from that time and then measure their blood pressure. And if they have a drop of 20 or more systolic, then that's diagnostic for orthostatic hypotension. Does that make sense, you guys?
Yes.
Okay.
Okay, what was the position? Sorry, didn't get that.
No, you're fine. So they're flat first, and then they're sitting up at the side of the bed, and now they're standing. So boom, boom, boom. So laying, sitting, standing.
Got it, thank you.
No problem. Yeah, problems, incontinence, blah, blah, blah. Okay. So just one thing I want you guys to know, if a patient has a or if they have a laparoscopic surgery, then one thing that might happen is that if the patient gets a laparoscopic surgery, they might inject carbon dioxide into the area, which can be uncomfortable for the patient, obviously. So when the patient is post-operative, we want to encourage the patient to ambulate. Again, I don't know the mechanism of action of this. I just know this is something we want to know, is that when they're post-op and they're able to walk, we want to encourage them to ambulate in order to absorb that excess carbon dioxide that has been administered during the laparoscopic surgery. So again, that might be a little confusing because it's kind of hard to follow the logic of that. But just to simplify and rephrase, in a laparoscopic surgery, you might see injection of carbon dioxide. When the patient is post-operative and they can ambulate, get them to walk in order for them to absorb the carbon dioxide that was injected. I don't know why they inject this carbon dioxide. It might be for visualization of some sort, but you want the patient to ambulate for that reason. Okay. So some of my last points, you guys. What are the two diseases that fall under inflammatory bowel disease?
Is one of them Crohn's disease?
Crohn's, and then we have the other one that's in the colon that's called
Ulcerative Colitis.
yeah, colitis. UC and Crohn's, right? So ulcerative colitis, the answer is in the name. Ulcerative colitis only occurs in the colon, right? Whereas Crohn's affects anywhere in the GI tract. It can be diffuse, it can be, it could be all over the GI tract, where in ulcerative colitis, it only affects the colon, right? So in Crohn's disease, again, we see these lesions everywhere, all over the bowel walls. We might also see fistulas. And one thing that this might cause is, of course, diarrhea. And with any patient that has diarrhea, we want to monitor for electrolyte imbalance. So if they come in for, a crisis due to their Crohn's disease and they have diarrhea, they can't have any electrolyte absorption, or they lose electrolytes because of their diarrhea, then obviously we want to look at their sodium, their potassium, their calcium, their magnesium, and their chloride. So again, you might not need to note chloride and magnesium at this point in your nursing journey for intro to med-surg, but remember, if a patient has diarrhea, look at their sodium and potassium levels because those can definitely be elevated. Okay. So I mentioned Crohn's disease, now to ulcerative colitis. With ulcerative colitis, the big symptom you'll see, no, the big sign, excuse me, the big sign you'll see is that they'll have bloody diarrhea and they'll have around 10 to 20 stools a day. So of course, that's extremely memorable because 10 to 20 stools a day, that's horrible. So ulcerative colitis, know that the indicating symptom is diarrhea, which is bloody, and they may have up to 10 to 20 stools a day. Okay. Does anyone know the difference between diverticulosis and diverticulitis? Okay, so with diverticulosis, what it pretty much is imagine this is like your GI tract, right? This is your intestines. What happens in diverticulosis is you kind of have like these outpouchings, these kind of balloonings of the intestine, not balloonings, but these sort of like small outpouchings on the, like in the intestinal wall, right? So the issue with that is that in those outpouchings of the intestinal wall, you can have things get stuck in there. Like you might have some food, you can have things get stuck in there, and what that might cause is diverticulitis, which is inflammation of those outpouchings, correct? So if the patient does have diverticulosis, what we want to do to prevent diverticulitis, which is inflammation of those intestinal outpouchings, is that we want to suggest to the patient to consume a diet that, you know, is low in fats, low in meat. You want to limit their red meat consumption, decrease their fat, and you want to promote a diet that is high in fiber, hydration, fruits, and veggies. Because imagine if your bowels are not moving, you guys, then it's like you just have stool sitting there. And it's like if you have those outpouchings, if the stool just sits there, it could possibly collect in those outpouchings, those diverticulum, right? So obviously that's why we want them to consume a fiber diet in order to keep their stool moving so it doesn't chill in a specific area and just deposit in the diverticulum. Does that make sense, you guys?
Can you mention again? You said consume low, no fat foods.
Yeah.
And then low red meats and have them eat fruits and vegetables. Is that what you said?
Exactly, and keep them hydrated as well, because hydration can promote bowel movements. Okay. Does anyone have any questions about that? Diverticulosis, diverticulitis? Okay. For sure, for sure.
So diverticulosis is the pouches in the intestinal walls, and how do you say the one? Wait. So the inflammation is the I don't know how to say it.
Diverticulitis?
Diverticulosis is the pouches, and then the other one is what?
Diverticulitis. So just itis at the end.
Colitis. Okay,
Yeah.
and that's the inflammation. Okay, got it. Oh, the pouches.
No problem.
And just one clarification, you said in the diverticulitis, the diverticulitis is the stool that sits in there, or?
Oh no, it's diverticulitis. What it means is just inflammation of those outpouchings, the diverticulum, right? My example with the stool was something that can cause diverticulitis. That's one mechanism.
But it's because it's sitting in the pouch and it's not moving, or that's going to cause the bacteria, or?
Yeah, exactly. Because
Okay.
again, that's why you suggest the high fiber diet to keep the stool moving. If it collects in there, then there's possibility of greater bacterial growth because it's just chilling there, right?
Right.
Does that add up?
Yes.
Okay, no problem. Mm, okay, so let's say a patient is scheduled for an abdominal paracentesis, you guys. What position do we want to keep them when performing an abdominal paracentesis? First and foremost, what an abdominal paracentesis is you're just draining fluid from the abdomen, right? And that might be due to the patient having ascites, right? So if we're draining fluid from the abdomen, we don't want to have them supine because, no, not sideline. We want to have them upright because if we have them upright, all the fluid collects at the bottom due to gravity. Or we can have them sitting, yeah. Yeah, we just want to have them upright. We want to make sure they're upright because if they're upright, all the fluid collects to the bottom, right? As if they are, laying flat, it's more spread out throughout the abdominal cavity. Yeah. So we want them to be upright so the fluid just chills at the bottom. It does. So obviously, when we do an abdominal paracentesis, we're not just going to stick the person. We're going to apply like lidocaine to the site, and then we stick the needle in to drain the excess fluids. Diarrhea. Okay, guys, one last thing I'm going to cover. I'm going to cover C. diff. So if the patient has C. diff, one thing you might see is multiple diarrhea that is foul-smelling in nature. So if a patient is positive for C. diff, right, what precautions do we enact? So is it going to be airborne? Is it going to be contact? Will it be
Contact.
Contact.
Contact, and we would put them on contact plus. What you'll see with contact plus is that you might see contact precautions with a brown circle, indicating contact plus and that the patient has C. diff, right? So if we have the patient, let me say this first. C. diff can be highly infectious, right? So obviously, when we're in that patient's room, we use gowns. We make sure to, of course, prevent infection as much as possible. Let's say I take care of a C. diff patient, right? When I leave the room, do I go for the hand sanitizer to wash my hands or do I go for the sink?
The sink.
That's right. We go to the sink because we don't want to transfer that, we don't want to transfer that to anyone and we don't want to infect ourselves. So the sink will be able to wash it out, right? Whereas with hand sanitizer, it might not kill all the C. diff because of the endospores, right? Obviously, if we have a patient that is under contact plus precautions, we want to make sure to use equipment specifically for them, right? Because we don't want to be transferring this bacteria, or I don't know if it's a bacteria. I think it's a bacteria. We don't want to be transferring this bacteria around. So obviously, if possible, we just use equipment specifically for that patient. Okay, you guys, I think that is the end of my TED Talk. Do you guys have any questions at all?
So I have a question. I know that you guys don't provide recording, but there is a website on, I think it's on YouTube, which says West Coast University, PAL, West Coast University, LA. So I just want to know if you guys are going to put the recording there or...
That is a wonderful question, and I was just going to get to that. You guys, all of you can access my recording at this YouTube channel, okay? And I don't know how long it's going to take for them to upload, but I know the person that tutored pathophysiology, I don't know when they tutored pathophysiology, but their video was uploaded a day ago. And again, we had these tutoring sessions, we have to have these tutoring sessions Monday through Friday, right? So it's like my video is bound to be uploaded. Again, you guys have my email. I'll put it in again. If the video is not up within 3 to 4 days, just contact me and I'll contact the coordinators for PAL.
Yeah, because I was in a tutoring session. I don't remember, it was Tuesday or Wednesday, and for MedSurg, but I can see the recording in that YouTube. So I'm not sure how long does it take to like upload the video there. So that's why I was asking. We had we had clinical today, so we couldn't make the tutoring, so it would be awesome if we have the recording, so that's why.
I again, like if it's not up in 2 to 3 days, just contact me, you guys, and like I'll ask the senior coordinators like when it'll be up, and I'll have an answer for you guys.
Okay, thank you so much.
Yeah, of course. And like for anybody that can't attend my sessions, like feel free to let them know that the recordings are going to be on this channel, because I know it's a very busy term for you guys. You have 4 classes and you guys have other obligations too. So I know, maybe there was someone that couldn't pull up today because they were busy. So, let your classmates know that the recordings are gonna be on.
Yeah, thank you so much.
No problem, no problem. Any questions, you guys? Anything about content? If you don't have questions about content, I could always, spill my brain regarding how I studied for Intro to Med Surg, or what I felt like helped me. Or just like, if you guys have questions about anything, like it's your time right now, from 1 to 3.
You had Professor Sarkisian, right?
I did.
Okay, so what did you study for her class?
So what I did, I think what helped me most was reading the ATI, or not ATI book, excuse me, reading the MedSurg book, but not the whole chapter, okay? Because Professor Sarkisian, what she's gonna do is she's gonna lecture on certain topics, correct? And those are the topics that are gonna be on your quizzes, right? With Professor Sarkisian, the bulk of how she tests and how she goes about things is based on her lecture, and that's fair because it's like that gives indication on how to prepare, you know. So what I would suggest to all of those that have Sarkisian, make sure to highlight the broad topics she mentions during class, right? So interventions for diabetes, assessment for diabetes, etc. The broad topics, right? And highlight all those broad topics once you finish your lecture. Once you start studying in the book, only study those broad topics, correct? Because what happens sometimes is that some students, they might feel like they have to read the whole Intro to Med Surg chapter, right? And the problem with that is that there's some things in there that are related to intermediate Med Surg, possibly advanced, and that's for intermediate and advanced, you know. I know everyone at West Coast already has so much already, so focus on the broad topics she mentions in her class. That's my suggestion to you. That's how you should go about your studying. And also, if you can attend the ATI and collect specialist sessions, go to those and of course do the practice quizzes. Because I think, like obviously it's not going to be like everything, but at the same time, just having exposure to different questions is going to help you, because it remember, it's not only knowledge for Intro to Med Surg, but also test taking skills, and the more exposure you have to the questions, the more familiar you're going to be, and the more prepared you may be when you face questions that are similar or of the same content when you take your quiz. What else? One last thing, attend her tutoring sessions. Attend her tutoring sessions and ask her all the questions you have, because she provides a lot of clarification on it. And I think it's good because you see it from her perspective. Again, the PALS tutors aren't professors or aren't experts, but she's a content expert. So she'll be able to provide you a firm answer with your questions. So attend her tutoring sessions as well. and ask as many questions as you need to. That's my advice and how I went about intro to med-surg.
I have a question.
Mhm.
What would be the patient teaching for Crohn's disease and UC? What would be the patient teaching?
Let me see. Give me a second. See, of course. Oh, whatchamacallit. I want to put this up in case any of you plan on heading out from the session. I'm just going to share the QR code all of you can use to kind of show your attendance for the session. I just want to put that up right now. Um, 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 um. Sorry about that. Share screen. Okay. Let me know if you guys can see this.
Yes.
Wait, what do we do with this?
So all you have to do is pull out your camera and then scan it with your rear-facing camera, and then it'll pull up a link for you to check in, just stating how long you were at my session, who is your tutor, etc. And again, this helps because I think your professors can see this data and see who's attending sessions. So it shows a sense of merit, you know? Let me know if any of you have difficulty accessing this, okay?
Yes, I do.
I
Let
can
me do-
scan also.
Oh wait, sorry, go ahead.
I can't scan.
Oh, you
I don't
can't
know
scan?
how should I do that?
Okay, so what you want to do, or did you try your rear-facing camera?
Yeah.
Okay, so I'll scan it myself and I'll send you guys the link.
Oh, okay. Thank you.
No problem. Dun, 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 dun.
I think too, depending on what type of phone you have, I had to actually download an app in order to be able to scan it.
Oh, you do?
Yeah, well, I
So-
have Android, so I had to download the app.
Oh, shoot. Okay, sorry about that.
But it works. No, I had already done it from before because I guess for PALS, that's the way it was gonna go on from last term. So
Let's have you check in. Let me pull up the link right now. Where? Hold on. Where is it? Sorry, guys. Give me a quick second. Nonetheless, how's the term been going? How was your first quiz, you guys?
Was
it
good.
okay?
Good so far.
Oh, really?
Yeah.
Oh, snap. That's awesome. That's great. It's always a good feeling to, like, you know, do well on your first quiz. But,
I just missed one question.
what, you just missed one question?
Yes.
Do you want to be like a co-tutor with me?
No, I'm okay.
Oh,
I have to
please.
study and take care of my two kids.
No, oh my goodness, that's amazing. Wow. That's that's really awesome. Oh my goodness. Okay, so I posted the link in the chat.
Yeah, I got it. Yeah, I
Okay.
can do it.
Fill it out and, you know, feel free to head out whenever you guys. I will answer. Okay, so going back to Crohn's disease, ulcerative colitis, patient teaching. Okay. So it's not necessarily patient teaching, but if a patient has Crohn's disease or ulcerative colitis, you want to have a registered dietitian consult, right? Because if they have that diarrhea, if they have that loss of electrolytes, obviously they're at risk for nutrition imbalance, right? So you want to discuss with the registered dietitian to develop pretty much a meal plan for the patient. So they get that calorie, they meet their calorie needs, and they also replace their electrolytes, and they prevent their weight loss. One other thing you can do is that you can teach the patient to lower their sugar and fat intake, not use NSAIDs anymore if they're overusing it as well. And you also want to tell them to stop smoking because that's something that can contribute to inflammatory bowel disease, ulcerative colitis, Crohn's disease. Does that make sense?
Yeah, thank you.
No problem. All right, you guys, I'm gonna be here till 3 if you guys want to head out. I hope you have a wonderful day. You guys got it. Of course, and if you want to come back, come back. It'd be cool.
Thank you.
Thank you.
Of course, no problem.
Thank you. Have a good weekend.
You as well. Enjoy it, you guys.
Thank you so much for your time. Thank you. Have a good one.
Oh, thank you for putting up with my lame jokes. Dita, did you have a question?
No, I'm just trying to go and fill out the form that you sent to us.
Oh, so you're leaving me?
You have a question, but I'm not sure that because I just missed a question. It was, let me go and find out by any chance. What was the question that you're asking for? What is the position for which disease that we should leave the patient upright or Fowler position?
Oh, okay. So if a patient is having an abdominal paracentesis, right? So what that is you're draining fluid from the abdomen, right? We don't want them supine, we want them upright.
No, understand. Oh, what just to know, yeah, what is the name of the disease?
Ascites. Ascites.
Oh, okay. And the other one was diverticulitis, and the other one, or only just you just talk about the diverticulitis?
Diverticulitis, that's the one where, remember, diverticulosis is the outpouching. Diverticulitis is infection of those pouches.
Okay, thank you so much. Thank you.
Of course, of course. Have a good weekend, okay?
You too.
Thank you.
Thank you so much.
Okay, Beta, I'm gonna end the session. Take care, okay?